All right, we are live.
All right, good morning. It is April 23rd. This is the Senate Health and Welfare Committee meeting, and we are looking at the issues related to COVID-19 response. And one of the issues that we have taken testimony on recently is the availability of medications, the concern about medications that are ordinarily used for treatment of specific diseases being available to folks who need them when they might also be used for COVID-19 treatment. And I've asked our Ledge Counsel, Jen Carby, to give us an overview or insight into what might be happening in other states. So Jen, thanks for being here, and we'll let you start us off.
Okay. Jennifer Garby, Legislative Counsel for the record. So yes, you had asked me what other states are doing, particularly around potential shortages of hydroxychloroquine and chloroquine. I also looked, there's a lot that seems to be going on around azithromycin as well, which is often used in conjunction with hydroxychloroquine. In general, states seem to be doing a lot of direction to their pharmacists to use discretion. Phrases used like using discretion, caution, or professional judgment in filling prescriptions for these medications. Some states had specific provisions saying that hydroxychloroquine and chloroquine are not to be used for COVID-19 prophylaxis, so as a prevention drug. Some of them had some language saying unless it becomes accepted after peer-reviewed evidence, or if the FDA or CDC adopts prescribing guidelines saying that it is appropriate for that use. Several states had quantity limits. So when pharmacists are filling prescriptions, they, in a lot of cases, would be limited to dispensing a 14-day supply, or in a few cases, a 30-day supply. There were also limitations on refills. For the most part, no refills, although for a number of these, they were limited to, or the restrictions were limited to newly established prescriptions. So if somebody already had a prescription for this medication, they'd been taking it, for example, for a chronic condition like lupus or rheumatoid arthritis, they could get a larger day supply, higher number of days supply. They could get refills, but it was really looking at new users of these medications. One state, Nevada, actually said no new prescriptions, no prescribing or dispensing of hydroxychloroquine or chloroquine for COVID-19 or for any new diagnosis made after March 23rd. So that was one of the sort of the strongest prohibitions. Several states said there must be a COVID-19 diagnosis confirmed or a COVID-19 diagnosis code included with the prescription. Some states had specific exemptions for people with chronic conditions, just a blanket exemption or an exemption for prior prescriptions. But as I said, a lot of states also restricted their guidance to patients newly prescribed one of these drugs. Some states' boards of pharmacy or other executive offices directed the pharmacists to monitor their supplies of these medications. Some states required or encouraged prescribers to document the diagnosis that they were prescribing the medication for. And then we have looked, I think, a bit, and you'll hear later from the Secretary of State's office on Vermont's executive order, or the emergency regulatory order. Vermont's applies to a number of drugs, seem to apply to more drugs than just about any other state that I saw. So going beyond just the hydroxychloroquine, chloroquine, and azithromycin to include a number of others, most of which I will not try to pronounce for you. But just as a reminder of what Vermont's does, it directs pharmacists to apply enhanced drug utilization review by requiring that the prescription order includes a documented diagnosis from the prescriber. So that was consistent with what a lot of other states were doing. that the diagnosis and drug are plausibly within the scope of the prescriber's practice, if known. There wasn't much that I saw from the other states about looking at the prescriber's scope of practice, so that was a little different. That the drug is reasonably indicated for the diagnosis as indicated by FDA approval or support by credible literature, meaning literature upon which a reasonable professional competent in clinical pharmacology would rely. Again, there was some reference in other states to FDA approved uses of medications, but this was different wording. And that the drug is not prescribed in a quantity manifestly in excess of the patient's anticipated need. So this kind of goes into the use discretion and professional judgment category, but looking at quantity limits without actually giving a certain number of days supply. And then the Vermont emergency rule goes on to say, regard as illegitimate and refuse any newly established outpatient prescription drug order that does not satisfy the required elements of enhanced drug utilization review. And then it also talks about taking reasonable steps to protect access for patients already prescribed these medications for established maintenance needs, or who may be newly and legitimately diagnosed with conditions for which these drugs are indicated. So some differences between what Vermont has done and other states, particularly in this area of the newly prescribed drugs. A lot of other states seem to have a pretty blanket prohibition on or limitations on newly prescribed drugs. Vermont's is looking at also protecting access for patients who may be newly and legitimately diagnosed with a condition for which the drugs are indicated. So that's an overview of what I found in looking around at other states. There's actually some really good summaries online, and that's what I was looking at. If it would be helpful, I'm happy to share a link to one of those with the committee. I was looking at the National Alliance of State Pharmacy Associations.
That, I think that would be helpful for us just to look at and get a sense. I'm going to ask Lauren Hibbert a quick question before we move on. Lauren, which day did you testify and provide us with the guidance from the Secretary of State's office? I've been trying to locate it.
It was last week, I think on Thursday or Friday. Let me just look at my calendar.
Yeah, it was. That's what I thought. It's not under your name under the witness section, so
I think it may be under Gabe Gilman's name.
Okay. All right. Well, we'll find that. Nellie, maybe you could help us find that. That would be good.
I can send that one, and Nellie can post that under Lauren's name.
Perfect.
If that works. Okay.
Yeah, that would work.
So Nellie, I will include this in the email I'm about to send you.
Thank you. I meant to look that up before we started, but we got tied up in our committee, in our full Senate. Thank you, Lauren.
Thank you.
So we're going to move on to testimony. And I want to thank everyone for being here and being so patient. I very much appreciate it. We have folks from Blue Cross and Blue Shield. So Sarah and Brian are here so do you two have testimony prepared together? How do you want to proceed?
Sure. Brian's going to do the testifying, and then if you'd like us to provide written testimony afterwards, I can do that.
Thank you. Okay. Brian, thank you for being here. It's good to see you.
Good morning. Good to see you too. Good to see everybody. I'm Brian Murphy. I'm the Director of Pharmacy and Vendor Management at Blue Cross Blue Shield of Vermont. So with regards to what steps Blue Cross Blue Shield has taken to prevent stockpiling of these medications, we, at the very beginning of April, we put in a couple of changes into our program. They focused around 5 separate drugs: hydroxychloroquine, chloroquine, azithromycin, Coletra, and albuterol. The way the program works, anyone that was filling the scripts in the past will just go ahead and be able to continue to get their medication. So it's basically grandfathering in any of those existing users before those drugs started becoming publicized in the media as potential treatments for COVID-19. For new starts, for new prescriptions that come into the pharmacy, we do have now a prior authorization on those medications. So if it comes through with a approved indication from the FDA, it's a non-COVID indication, lupus for hydroxychloroquine, for example, then that will go ahead and be approved. And then once it is approved, normally we allow people to get a 90-day supply at their local pharmacies. That is held at a 30-day supply for these medications. Now, we'll remove these restrictions once this pandemic ends, and we'll go back to the way things were before, where we didn't have any authorization on these medications. But during this time period, we do have the prior authorization and prior authorization for new starts, and a 30-day limit for all scripts on these medications. Any questions about that?
Yes, actually I do. I have a couple of questions. One, just in terms of the 30-day, does this in any way put the folks who have these chronic illnesses at greater risk, having to go back after 30 days rather than a 60 or 90-day period?
Yeah, they can get an early refill, so they would be able to get 60 days at that time. And
Okay.
a lot of local pharmacies do offer home delivery. They'll go ahead and ship to people's houses and so forth. And they've been very generous in providing that service without an additional charge. So
Okay.
they are able to go ahead and do that.
Okay, good.
Yeah.
Thank you. Go ahead.
I was just going to say, before we got these in place, we did go back and take a look to see how much additional scripts had been filled for Blue Cross Blue Shield members. And while we did see an uptick, it wasn't a massive wave. It came to about $3,300 in additional scripts for hydroxychloroquine. So while there was some uptick, it wasn't a massive wave that we saw. Prescribers were generally pretty well. And we have done a retrospective analysis. We did find a handful of prescribers that were prescribing for themselves. And so we've gone back and we're just doing some outreach to them to let them know that, they're not to be prescribing for themselves and so forth. But just to alleviate any sort of concern, at least for Blue Cross Blue Shield's population, we didn't see a big wave before these went in.
Thank you. My other question is, have you identified any places where you've had difficulty with patients accessing, and maybe this might be a question for some of the pharmacists who are on the call, but have you found any pharmacies that have been resistant to giving out the amount of time that Blue Cross and Blue Shield is authorizing?
Pharmacies have put in their own limits as well. And I believe that they're going to be represented here later and they can be able to speak to that.
Mhm.
And we did hear from a couple members where there's some confusion as to whether or not it was a Blue Cross policy or the local pharmacy policy and so forth. So we're trying to work through those and everything. So, it's a little bit of belt and suspenders right now, and that's creating some confusion for folks. I don't have evidence that there's a large number of people, but there are some different policies in place at different pharmacies that could be causing a problem. I know my mother-in-law has lupus, and when she went to fill her script, CVS, the pharmacist was scrutinizing her prescription, saying like, "Are you sure you really do have lupus?" And he was like, "I've been filling this for months." So there is a general vigilance to try and prevent stockpiling. That goes through payers and pharmacists and everything. So we're all trying to find our way through, and I think we're all keep on communicating with each other, and we'll get it right.
All right, thank you for that. That's helpful. Any other questions, committee members? All right, Sarah, did you want to add anything at this point?
No, all set. Thank you.
All right, thank you. Brian, thank you.
You're welcome.
And now we have, I'm looking at my agenda. I'm not taking my attention away from the meeting, but I need to see who's next. Oh, Lauren Bodie. Is it Bodie or Bode? Where's Lauren? Lauren Bode. There she is.
Hi, yes, it's Lauren Bodie.
Bodie, welcome. And you are Vice President of Vermont Pharmacists Association, and you work at the Albany College of Pharmacy.
Yes, that's right. I think also on the line we were supposed to be hearing from Jeff Hobart.
Yes.
Okay.
Is he the one that you are going to hand off for testimony? How are you doing that?
Oh, it doesn't matter overly which order we testify in. Although I think he is going to be better positioned to address some of
Okay.
what the supply challenges that he's seeing in his pharmacies.
Okay, so why don't we, Jeff, why don't we go to you and have your testimony? And I'm looking to see, you do have testimony online, I thought so.
Yep.
Terrific. Thank you for being here. So why don't you introduce yourself for the record and go ahead.
Thank you. Jeff Hochberg, President of Vermont Retail Druggists and Director of Pharmacy Operations at Smile City Pharmacy Group. So I know you guys want to kind of focus on hydroxychloroquine.
No, Jeff, just as clarification, there are a number of drugs that have been identified as effective, and some of them we can pronounce and some of them we can't. And so, and I know that the Secretary of State's office, OPR, has put the list out that's more extensive than hydrochloroquine. So we're open to the full spectrum at this point.
Okay, yeah, and I think just to give you guys a little insider trade information, none of us know how to pronounce the names, so we just make it up as we go. But I would start by just throwing out an urge of caution regarding two drugs in particular, and that's the azithromycin and the albuterol. Those drugs have numerous utilizations, and in the coming months, we're going to see those. So certainly when we get regular cold seasons and allergies, rescue inhaler is going to be important. Azithromycin as a standard antibiotic treatment is important. So we just have to be careful about what kind of stops we put on the insurance side and in the adjudication process. And I would just consider that as we move along. But in the general scope of things, most of these drugs are very difficult to get at this point in time. As a matter of fact, every single drug in the pharmacy catalog from wholesalers is on allocation. Okay, so no matter if it's for COVID-19 treatment or if it's for allergies or asthma or anything else, every pharmacy across the country with every single wholesaler is allotted certain amounts of product they can get each month. Okay. And
are you gonna talk about how that distribution is being determined?
yeah, so I mean that it's basically determined upon what they use a process called fair share allocation. It's based upon past utilization, so, and past order history. And that's how it works. Most wholesalers are actually closing secondary and tertiary accounts so that they focus their attention to prime vendors and prime accounts. The reason for that is because when the pandemic really first took hold and we started making aggressive actions, there was a big call for everyone to get 90 days, stay at home and all that. In the last 2 weeks of March, pharmacy businesses across the country, and Vermont included, my stores included, saw a huge uptick in volume. Large amounts of prescriptions were going out the door very quickly. Supplies were being depleted very quickly in central warehouses across the country. So these stop measures were put in place right off the bat. And they're going to continue. The drugs, the pharmacists, I think, that I've spoken with have all identified, hydroxychloroquine and allocating that for existing patients and certain disease states only. And that goes across the board for everything. Inhalers, we'd already mentioned albuterol, but every single inhaler is on allocation and very difficult to get. So we limit people as to how much they get so that we can dispense more out to the general public. One person getting 90 days supply of a product doesn't help the community when the rest of the community can't even get a 30-day supply. So we have to be vigilant in the stores. And I think most pharmacies are using their sound judgment to do that appropriately. The bigger concern that I just want to raise attention to, and this may be looking at things, the glass half empty, this is going to be a problem that extends well beyond this list of drugs, okay? Every single drug is going to have a problem, in particular generic drugs, which is 90% of the volume of business in the state, okay? As what I've learned in talking with several executives of various wholesalers, that manufacturers typically hold about 6 months worth of API, that's the active pharmaceutical ingredient, in their stockpile. That's enough to get by for a long time, and they can probably stretch it out to even a year. But what's more concerning is the excipients, and those are the inert ingredients, the fillers that actually make up the tablet. Give it the red tablet, the blue tablet, whatever have you. Those are they do not stockpile those in their plants, and those are going to run out first. And as the geopolitical tensions continue to mount, and if this pandemic and lockdown exists in our country and in other countries, in particular China and India, if it continues for a long time, we're going to be in real trouble across the board of pharmaceuticals in 6 months. There's definitely going to be more drug shortages throughout the summer. That's a guarantee. I promise it. And it's definitely going to be generic drugs more so than brands, just by the nature of the business. So it's something that we ought to really consider and monitoring. I don't know there's much we can do about it, but it's definitely something to be wary of. So
Thanks for the good news.
sorry, I wish I had better.
Listen, Jeff, thank you. That's very helpful. In terms of your understanding in terms of the manufacturing of some of these drugs, are we seeing any uptick of manufacturing in our country at this point, or any? I don't know. You probably can't answer the question about importation from Canada right now. That's something we've been working on, but
That's been turned off.
I know.
And it probably will be turned off for at least a year, if not 2.
Yeah.
Manufacturing stateside is a big push nationally. I think that goes across more than just pharmaceuticals,
Right.
but manufacturing generics locally in the United States is going to be a strong thing we're going to hear about from the Fed. And, there's going to be a lot of discussion about costs associated with that. But, I think the big argument is that if you were to raise generic prices 400%, in the grand scheme of it, that's really not a lot of dollars, and a lot of protection would be added to our capability of handling anything in the future. I think this is kind of a real wake-up call for us. I've talked about this many times with people, that we need to develop a better system to monitor what's going on in the supply chain and to better control what's going on, not just in terms of distribution, but in terms of economics. The whole package needs to be understood, and there needs to be an arm of our state involved in that, so that when pandemics hit like this, which there's a chance is going to cycle back around, if we're in a position like this again, little old Vermont with its 650,000 lives is a low man on a totem pole in getting product. We share distribution centers throughout the entire Northeast. The Northeast is one region, and it quickly gets diverted to Boston. It quickly gets diverted to New York and the Mid-Atlantic regions, as opposed to New England. So something that really concerned is the future, and we need to just kind of be mindful of that going down the road.
Yeah, thank you. That was one of the reasons I asked the question about how the distribution or the wholesale distribution was being determined for our state.
Yeah, there's logistics. Some of the reasons for the allocation are logistical. The big surge of volume that took place caused warehouses, when they normally pick, pack, and ship a product within, in 24 hours. Basically, what happens is pharmacies place orders for the next day, usually by 8 o'clock that following evening. The warehouses start picking, and by 2 o'clock in the morning, they're done. By 4 o'clock in the morning, they're out the door and being distributed. So that first thing in the morning, product is being dispensed all over the country.
Okay.
With this uptick, they've added about 24 hours to that process. So getting product next day is no longer a guarantee. And it's really just because they don't have the manpower in the various plants to pack all the stuff that they need and ship it out.
Thank you. The other question that I think we might have is, as you're talking about the demand going up and the supply going down, that also suggests increase in cost too. And you mentioned generic cost increases, but are we seeing increase in cost right now?
Not right now. We have not seen too much increase in cost. More than anything, everything's been stabilized on that front. There is an economic fallout to pharmacies because this all timed out with what's called DIR fees and direct indirect remuneration, which is nothing the state can necessarily do. It's really a federal matter. But just for example, in March, CVS Caremark began its DIR fee recoupment on every pharmacy in the country, and that averages to be about $35,000 a trimester for each pharmacy. So it's a large chunk of money at a time when pharmacies are looking to purchase more inventory for their shelves so that they can continue to supply. Reimbursement timing has slowed down. And that's just because of the administrative lag and everything. So there's been a credit crunch, and a lot of, fortunately, the wholesalers are helping with that, but a lot of smaller pharmacies are going to face some real pressures here downwind. They've maxed out their credit with their wholesaler. They haven't been reimbursed appropriately. And there's a huge demand that they continue to service the communities, and we need them to. So hopefully nobody has closed their doors as of yet that I know of. And I think everyone is doing the right thing and being judicious in how they handle this. But there's potential for some increased access issues in Vermont. And that's, when we're here during this, when we start opening things back up, we need to consider, how do we get the regular care back going? How do we get testing done across the board? And you'll hear from others that utilizing the pharmacies and the pharmacist in particular to the top of their license is so critical that we can engage the general public and get regular treatments back online, testing done, without jeopardizing the hospitals and how they're set up to handle the more intense and COVID treatments here and precautions that we may have a second wave of. So we need to engage the pharmacists and the pharmacies, but we also need to just be mindful of their economic positions. And I thank the committee and all the senators that are involved in helping with the frontline workforce assistance. I think that's going to be a huge thing. But it just, right now we're good, but time will tell.
Thank you for that. Yeah, that's helpful. Questions for Jeff Hochberg on this. I have a lot of questions. I'm kind of saving some of them because I think we might bump into the answers with further testimony, but I might come back later on.
Okay, thank you.
Thank you. I hope you can stick around for a little bit. Okay, good. Lauren Bodie, did you want to add some testimony here?
Sure. So I'll start off by echoing Jeff's thanks to this committee for their attention to this issue, and that overall the system does seem to be holding up so far. That's what we're hearing from our pharmacist members. What I'll also say though is that I think that we have gotten some things right in Vermont. That's been really helpful.
That's good.
Yeah. And so where, I absolutely agree with everything Jeff has said about the potential for some really potentially disruptive changes in our supply chain due to like the global nature of pharmaceuticals. I think that there's some tools that have been leveraged in the emergency order. Tools that were derived from a bill that was already in progress during this legislative session. That have been proving helpful and will continue to prove helpful as we address some of these challenges that we think are coming up over the next few months to a year. So in particular, therapeutic substitution we're hearing has been good to address the albuterol shortages. So, albuterol inhalers, they are all fundamentally therapeutically equivalent, and giving pharmacists the ability to sub one in for the other, regardless of which one was prescribed, has been really important in connecting patients to the therapy that was prescribed at the time they need it. We are also seeing some use of the emergency renewals of maintenance medications. Largely, providers have remained accessible for electronic refill of medications is kind of what we're hearing from pharmacists. But there absolutely have been times that they've not been able to get a hold of a provider if they're like not set up for whatever reason for electronic, and so not at their office. And being able to maintain continuity in a patient's care has been very important. And so these two things are we're both drawn from the bill that OPR brought forward in this legislative session. As a brief update, that bill was passed out of government ops and made crossover. But of course, now with the fate of the legislative session being somewhat uncertain, what I wanted to address with the committee is that there is a possibility, given the timing of the way this may unfold, that the emergency measures that we are currently utilizing to help sort of weather this disruption could phase out as we locally start getting healthier. However, given that this may be offset somewhat from disruptions in global markets, it could be that there's a gap between when our emergency measures lapse and when the measures initially proposed in the legislation may be able to be passed and enacted. So it's just something to kind of keep an eye on, that we wouldn't want to have that gap necessarily. We want our pharmacists to be able to continue to provide these services.
Can you share with us which bill you're talking about?
Sure. I'm sorry. It's 291, either Lauren or Theo. I can't remember whether 291 is the new number or the old number.
It's S220.
220. Okay.
Was that a bill, Lauren? You're really up on this a lot more than we are. Was that a bill that originated in GovOps?
Yes, it was a GovOps original bill.
And it has, we'll look at it.
I'm happy to send it to you.
Okay.
But it does have an expansion of pharmacist scope and an agreement with a lot of stakeholders on that expansion.
Right. And I think we looked at that in our committee. My memory, it's such a distant memory right now. The emergency's taken over our lives, but I believe that we did look at that in committee, so we'll go back and look at it again. Maybe there's a way to pop that out and have it happen. If it's an S bill, it has to also go to the House and back again. So we'll see. We'll talk amongst ourselves and see what we can do. Thank you.
Well,
Lauren,
and-
thank you for bringing that up. And I didn't mean to interrupt you, but that's an important issue.
Oh, not at all. And, I'm kind of looking into my crystal ball, and being a pharmacist, I'm a contingency planner. So this is, maybe none of this will come to pass. And I also hope I didn't speak out of turn, but when I was like looking at the emergency orders that came out regarding this, I was like, oh, that looks familiar. That is what was in the OPR bill.
So yeah, so your concern is the bridge between when that bill might take effect and when the emergency order ends. So we'll just have to be aware of the timing on that.
Right. Well, just keep an eye and make sure that we're able to help in the way that we have thus far been able to. The other way that bill is germane is that it also talks about some immunization authority. The reason that I think this is important was really highlighted yesterday in an announcement from the CDC, in that we're anticipating that COVID-19 is going to be around for a little while, and that we may very well see a resurgence in the fall, and that this resurgence could be particularly complicated by the commingling of the SARS-CoV-2 or COVID-19 virus with the influenza season. So I just wanted to note that one of the other things that this bill would do is expand, in particular, influenza administration ability by pharmacists. Currently, Vermont has one of the most restrictive immunizations authorities for pharmacists as it pertains to age. And so this is something that I also would want us to be keeping an eye on, because not that we don't want everyone immunized every year, but it is going to be a particular public health importance for this coming year. And so making sure that, pharmacists do have the authorization to provide immunizations in a broad public health manner, I think is going to be hugely important. And I will also say, as a pharmacist who has practiced in other states, that immunizing an 8-year-old is absolutely within the capabilities of a pharmacist, just as immunizing an 18-year-old is. And so this is another issue that I wanted to bring this committee, just kind of have on your radar, so that we are leveraging our pharmacists to support public health in this way.
Thank you.
And then, yeah, and then the last thing that we are kind of thinking on, again, we're kind of looking forward and seeing some things that we've been doing right in Vermont and making sure that we keep those things in place, is then also kind of like Jeff alluded to, we want our pharmacists who are already on the front lines of healthcare fully equipped to really engage in a real public health COVID-19 response. Technology is actually moving much faster than I would have ever imagined. And as it regards, screening, testing, treating, and vaccinating. We're going to want our pharmacists on the front lines doing these things in a coordinated public health response, meaning that there are likely some legislative or regulatory barriers that would need to be addressed, so that pharmacists are able to take care of the public in the way we know how to and want to.
Are you talking specifically about barriers that you would like to see removed during the emergency, or are you talking more generally about later on when the emergency order is lifted?
So depending on how the timing goes. So, in the emergency order, no, there is no specific authorization for testing or treating. We're not at that point quite yet. But it is approaching faster than I would have anticipated had you asked me a month or two ago. And so whether this falls into the emergency order or whether it's just something that would need to be addressed through the more usual channels, kind of remains to be seen as to how the timing all plans out. But I just do think it's something that we want to keep an eye on to make sure.
Do you have sort of the list of what you see as the barriers and what might be recommended for improvements? Not that we'll act on them immediately, but I think it's important for us to be aware of the things that you're thinking about so we can also consider them.
Sure. So in a general sense, you know, we do have the ability as pharmacists to order CLIA waived tests, I believe. So we do have some pharmacists who are doing these CLIA waived tests in the state. But I would need to sit down and look at people who are more versed in how this authority is written in the state currently. But globally, making sure that pharmacists have the ability to order, initiate, perform, and interpret those tests, that they are then able to bill for those tests, and then bill for any you know, subsequent treatment or immunization or whatever tool it is that we have in our public health tool chest at that time.
All right, thank you. That helps. Thank you very much. Anything else that you want to add?
No, it's just other than the other thing when we were talking with our pharmacists that we did hear is how they appreciated and felt that we had really good communication from our Board of Pharmacy, Office of Professional Regulations, and Department of Health all throughout. And that having that clear guidance has made navigating this considerably easier. I can also say from having like monitored how this is unfolding in some other states, that I have felt considerably more informed and secure in with our like OPR and Department of Health. And so just, you know, give good credit where credit is due.
Thank you. That you're absolutely right. We're very fortunate in our administration right now, having the administration that we've got. All right. So Heather Schuldis and Heather, are you testifying, or did you bring us Heather King? I see there are two Heathers here.
Tag team. Good morning, Senator Lyons. I just wanted to sort of give you, the committee, a little backdrop on the Vermont Association of Chain Drugstores. But yes, Heather's going to provide the testimony and answer any questions you may have. So I wanted just to tell you who we are. We represent traditional drugstores to supermarkets with pharmacies, from regional chains to companies with 3 stores. There's just over 100 community retail pharmacies in Vermont, which employs over 4,400 people. So that's a good workforce. Our association is represented by Rite Aid, Walgreens, Kinney Drugs, Hannaford's, Genoa Healthcare, and Price Chopper, which is where Heather is located. And Heather is also an officer of the Vermont Association of Chain Drugstores, just newly this year. So I'm happy to have her on board. I've provided Heather with the thoughts and questions that you gave to Jen Carby last week. So she will try and cover those areas in her testimony. But obviously, like you have already this morning, feel free to interrupt or ask her for questions or answers. And she has extensive experience in this field. So I'll kick it off to Heather now.
Heather, are you here?
I am here.
There you are. I'm sorry. You escaped my vision. Thank you for
am I on the
being
tile
here.
screen now?
Yeah, you're here. Thank you. Thanks for being here. And Heather, thanks for the introduction. So Heather King, why don't you introduce yourself for the record, and then we look forward to your testimony.
Sure, thank you. So I am the Pharmacy System Coordinator and Compliance Officer for Price Chopper Market 32 Supermarkets. I'm also the chair of the New York State Board of Pharmacy. So I have been very close to this on the New York level also. But I do also want to reiterate what Lauren said about Vermont doing an excellent job. I obviously am in a position to be able to compare states and their responses. So great job. And I think, Vermonters do feel more comfortable with the response. And there are many fewer questions in Vermont than in New York. So that's a great job. Thank you. We definitely appreciate the opportunity to comment on the impact of the COVID-19 pandemic on community pharmacies. As a member of VACDS, we commend the state of Vermont for taking proactive steps to ensure continued access to essential medications by preventing product shortages. We also appreciate the Vermont Senate taking the time today to learn more about how pharmacies have been affected and have been proactive during COVID-19. March did show a run on all medications due to the panic and fear created by COVID-19. The allowance to refill medications early and provide a 3-month supply additionally did tax the supply chain. However, the pharmacy supply chain traditionally does contain 3 to 6 months of product. This includes the amount of product at both the wholesaler and the manufacturer. Therefore, there were a few days in community pharmacies and the chain pharmacies that were challenging due to the right sizing of inventory, but the pharmacies were eventually able to obtain the supply within a week or two. The exceptions are the products that are potential treatments for COVID-19. There were some struggles getting product thought to be key in treatment of COVID-19, such as maintenance and rescue inhalers, acetaminophen, and over-the-counter treatments for cold and flu symptoms. Once hydroxychloroquine and zithromax were touted in the media as a potential treatment for COVID-19, we did experience a dramatic increase in demand. Any available product was provided to state and federal governments first, and the remainder placed on allocation to the pharmacies by wholesalers. This means each pharmacy could only be provided a limited amount based on purchasing history. Current hydroxychloroquine patients with rheumatoid arthritis and lupus often use the early refill and 3-month supply allowance to obtain the medications. Therefore, the demand was quickly drained, or the inventory was quickly drained. Additionally, we did see a number of orders for hydroxychloroquine and zithromax sent to pharmacies by prescribers to have on hand just for the in-case scenario. Those orders have dramatically decreased with the guidance provided from the Department of Health, VMS, and EVMNC, and they've had the intended effect. Pharmacists now collect and document the diagnosis code with each new order for these medications and can educate prescribers on OPR guidance if needed. We are seeing stops on all new medications from most PBMs and insurance plans that mandate us making sure we've collected a diagnosis code. We are not currently experiencing any shortage on these products for hydroxychloroquine and zithromax, and believe at this time there's enough supply to service those patients with chronic illness such as rheumatoid arthritis and lupus. China is heavily involved in the production of most of the world's active pharmaceutical ingredient, as Jeff mentioned before, as well as the inactive ingredients to produce these medications. India plays a large role in the production of the completed drug product. With these two countries so heavily impacted by COVID-19, there is an expectation that drug supply issues will be seen in 2 to 6 months. Key factors are many Americans refilled a 3-month supply or more of their medications, depleting the already manufactured inventory proportionally. Delays in chemicals from China and the finished product from India will lead to a gap in the supply. There is really no question about that, it just is when. The United States no longer has the capacity to provide the ingredients and provide the manufacturing of all of these products. With the allowance of early refills, in addition to the allowance of a 90-day supply, pharmacies are doing their best to try and balance between patients obtaining an excess amount of drug and having an adequate supply on hand. Pharmacies are working with their wholesalers, and those pharmacies who warehouse some of their own product are feverishly working with manufacturers to source more product. Additionally, relaxing the rule in Vermont to allow pharmacists to substitute equivalent product when the ordered product is not available has been extremely helpful when shortages are experienced, and will continue to be extremely helpful in the future when we anticipate these shortages occurring. There's some other challenges pharmacies are seeing during this pandemic that we didn't really anticipate. Buprenorphine is an opioid used for medication-assisted treatment to treat addiction. Relaxation around early refills for these types of medications is leading to pharmacies hitting their maximum allowable amount of purchases for that drug for the month. These limits are called thresholds and are imposed by wholesalers in order to be compliant with DEA rules. Some pharmacies are finding it difficult to provide a supply to their current customers because they are denied shipments due to hitting these thresholds. Additionally, pharmacies that hit their order thresholds for these products or place orders of increased size or frequency are often reported to the DEA by the wholesaler, which can then have them turned in and create troubling audits, or also just create fear amongst those pharmacies and those pharmacists. These two circumstances are leading to some pharmacies turning new patients away for buprenorphine treatment for addiction. This is not a new issue. However, it is having a greater impact during this time of additional stress when the need for addiction services may be on the rise. Even though this is a federal issue, we thought it important that the legislature was aware. Additionally, clinics that treat addiction are closing, and long-acting injectable drugs such as Vivitrol to treat addiction can no longer be administered in these closed clinics, leaving the patients without any treatment. Some of these patients are then switched to oral treatment such as buprenorphine, creating additional stress on the highly controlled supply of buprenorphine sent to the pharmacies. Several states have made the move to allow pharmacists to administer injectable drugs, such as this Vivitrol, in order to ensure continuity of patient care, especially in yes.
Can I ask you, do you have a sense that what you're talking about with the Vivitrol, is that happening in Vermont?
We have reports that we have had some closed clinics where the patient has had to contact a phone number provided on the Vivitrol package to find a provider to actually provide that injectable drug to them. So okay. I'm not sure how widespread it is, but we have had reports of this occurring in Vermont and New York as well.
Okay, thank you.
You're welcome. So in these injectable drugs, the two main areas that we're seeing the need is in diabetes and in mental health, and which it of course does include the addiction services. Given this unprecedented pandemic and the need to ensure the health of our communities and the health of the state's economy, we do urge Vermont legislators to act to remove any remaining barriers for pharmacists to order and test for COVID-19 and administer any forthcoming FDA authorized vaccines. Doing so will expand access to testing and treatment in neighborhoods across the great state. As we have all heard, COVID-19 testing is a critical element in reopening America. That means expanding accessible testing. Recently, the U.S. Department of Health and Human Services released COVID-19 pharmacy testing guidance, authorizing pharmacists to order and administer COVID-19 tests when appropriate. Considering the tremendous public health need to increase testing and the accessibility of community pharmacists throughout the nation, pharmacy testing is an important solution in the pandemic response. Community-based testing for infectious disease, including influenza, group A strep, HIV, and hepatitis C, have been well-established in a well-established practice for many years and is already occurring throughout this country. However, despite the federal issued pharmacy testing guidance, it is imperative that states remove any remaining barriers to testing COVID-19 conducted by community pharmacies. 19 states, including North Dakota, Louisiana, and Ohio, currently allow pharmacists to administer COVID-19 point-of-care tests via existing statutory authority or issued guidance. Therefore, we urge your leadership to take affirmative action to remove any unintended barriers to access to this testing. Not only is increased testing capacity essential in curbing the spread of COVID-19, immunizations will be the next important milestone, as was previously discussed by Lauren and Jeff. Hence, the time is now to take action to accelerate the availability of any forthcoming treatment and vaccine authorized by FDA. Importantly, the Center for Disease Control and Prevention existing pandemic plans heavily rely on the use of community pharmacies nationwide to meet public health goals. Vermont pharmacists administer CDC recommended immunizations to patients 18 years and older via prescription or written protocol. Across all states, pharmacies provide vaccines to protect patients, with approximately 1 in 3 flu shots being provided at pharmacies. In 2009, the H1N1 pandemic, and in other disasters and emergencies, pharmacies actively engaged in emergency response efforts using strong local presence to administer vaccines to patients quickly and safely. Accordingly, we strongly urge you to expand existing pharmacist immunization authority to include the administration of FDA authorized vaccines to patients of all ages in anticipation of COVID-19 vaccine, and to do so without any needless administrative burdens. Just in summary, we do appreciate the tremendous and diligent efforts taken by Vermont leadership, Office of Professional Regulation, and the Vermont Department of Health, as well as the General Assembly, for quick work to address these issues during the pandemic. As the pandemic response unfolds, we welcome the continued opportunity to work with you to further expand access to your citizens through increased engagement of pharmacies. So,
Thank you. That was very comprehensive. I have a couple of questions and then we'll open it up to the committee folks. If you have that testimony in writing, could you please send it in to Nellie and we'll put it up on our webpage?
yes, Heather Schultes will do that for us. Thank you.
Excellent, thank you. So, and as you're talking, understandably, it went to the vaccination issue, which becomes complicated when we think about this as a long-term request. And we do know there are bills in regarding pharmacists and vaccination, but certainly during the epidemic, should there be a vaccine developed, an effective vaccine developed, then that would be something we'd have to consider. And it doesn't hurt to begin that conversation early. So I want to thank you and the others who have spoken to that for your comments. I do have a question regarding, because of your position in overseeing so many different pharmacists, you represent P&C, I understand that, but you also have a finger on the pulse for others. Are there any pharmacies that are limiting some of the drugs that we've been talking about, that such as azithromycin or hydrochloroquine, and there are others, albuterol maybe, but are there any pharmacies that are limiting access by patients who have a regular need to less than a 30-day supply?
So I can, there's a couple different issues on that. So first of all, no, at this time we have not seen any pharmacist or heard of any pharmacist cutting back the supply that was intended for customers that already have an existing condition or have already received that particular prescription. There have been reports, and I'm not sure, where this is occurring, of pharmacists turning away new prescriptions. And I've heard of some mail order pharmacies actually turning away prescriptions for new patients, saying you need to get, a different drug ordered. We have heard some reports of that, but I can't substantiate that for sure because I did not see that firsthand. The pharmacists that I work with and in Price Chopper and Market 32, we have not had to cut back any supplies. We have discussed by looking at our inventory as the numbers get really close to getting low, what our capabilities are. We do have insurance contracts with PBMs, and if the doctor writes for a 90-day supply, and the insurance covers a 90-day supply, through our insurance contracts, we have to fill for 90-day supply. We can't limit them to 30. If we do limit them to 30, they're still owed the remainder. So it's not like we have the capability to really cut back and not fill for that entire amount. We have not had the need to do that. Now, if something comes up where we do experience an extreme shortage, we could cut back, fill for 30, but we do owe the patient the remainder, and they would not be charged for the medication and would then have to come in and get those additional medications or tablets, but they are still certainly do those medications. So, I mean, we've heard a lot of different things, but we have not in Price Chopper Market 32 and in several of the other chain pharmacies that we've spoken to have not experienced shortages besides that first couple of weeks where, the government ended up taking half of the drug and then we were just put on allocation.
Yeah, thank you. Thank you. And right, and I know I have read about India sort of cutting off the exportation of hydrochloroquine. So that the question I have actually for all of you, and maybe I'll hold it for Lauren Hibbert a little bit, but how do we get the word out that a drug is not effective or as effective as all the hype has made it? How do we get that word out so that people are not interested in prescribing it? I've heard recently from a doc who wanted to prescribe hydrochloroquine for a COVID patient or someone who is being diagnosed as COVID in the hospital. And knowing that there might be something more effective, like taxazilumab, the biologic, that or some other drug. How do we get the word out that now hydrochloroquine isn't the be all end all? I'm asking it. I don't expect an answer right now. So, and I'm going to let Lauren Hibbert answer that question, but it's a general question going forward. Any questions from the committee for Heather King? No? Okay.
Mhm.
All right. We're good then. Heather, thank you very much. We
Thank you.
appreciate your time and your testimony. And if we can get that electronically, it would be greatly appreciated.
Certainly.
All right, great. I think Lauren Hibbert is next up. Let me just make sure I have my agenda. You are. Lauren Hibbert, thank you for being with us again.
Good morning. For the record, Lauren Hibbert, Director of the Office of Professional Regulation. To your question, Madam Chair, about who should get the word out on the ineffectiveness of drugs, I think that would be a coordinated communication from the Board of Pharmacy under my office and the Department of Health. We've been trying to coordinate messaging and really have the Department of Health lead on what is effective and what's not, or PPE, or any specific COVID-related question that's coming. That's medical. We're trying to coordinate that with the Department of Health, and I would want that messaging to come out from the Department of Health. There is, I'm sure you all are aware, the HAN network, the Health Alert Network. So I would assume that they would want to send out a HAN, and then we would probably do a subsequent mailing.
So I keep an eye on the HAN just because I have a physician in the house, but it doesn't come to me. But I don't think we've seen this one yet about maybe it has come out, hydrochloroquine.
We have seen a message from the Department of Health about careful prescribing, but we have not seen anything that says that it's not effective.
Yeah.
I think that's of wide debate. I mean,
yeah.
This is a little bit, my brother-in-law and my sister are both pulmonologists at Mass General, and they both are on, looking into this issue, and they are on many, nationwide groups about the effectiveness of this medication. It's really up in the air and not proven yet. So,
right. And some of the early results indicating that it's better used early on in the disease, and then it's more effective. So there's all kinds of things going on. Where our concern, I think, here is to ensure that it's available for people who have long-term needs for each of the drugs that we're talking about, make sure that people with chronic conditions or being treated for a specific condition have access, and that we're not trying to stop the use of any of these drugs for COVID treatment. But as you know, whether or not they are it's therapeutically determined through FDA and CDC. Can you talk a little bit about the order that you have sent out? I know we've heard it once, but I think it will mean more to us now that we've been through listened to the pharmacists.
Sure. So I issued an order with our new regulatory authority on April 10th. It does, as Jen Carby outlined, it does include more medications than some other states have. These are medications that we had heard could cause, could be the subject of shortages based on use for COVID treatment. And what we did is utilize something that was already in Vermont statutes and rules, Administrative Rule 10.2, which requires that a pharmacist do a drug analysis, a drug utilization review is the term of art. And so it's an expanded use of that drug utilization review. And as Ms. Carby said, it makes sure that the pharmacist reviews that there's a documented diagnosis, that the diagnosis and drug are possibly within the scope of the prescriber's practice. And we put that in because we had heard of some prescribers, a dermatologist prescribing this, just some prescribers that this would not be within their traditional scope. And so we wanted to make sure that it was a legitimate prescription. We had heard quite a few concerns, just like Blue Cross and Blue Shield found, of prescribers prescribing to themselves or to their immediate family. So we wanted to make sure that it was a legitimate prescription. And then that the drug is reasonably indicated for the diagnosis. So meaning that we really should not be seeing prescriptions for the prophylaxis or prevention of COVID, and then that the drug is prescribed in a quantity that is appropriate. So we did not want to see 90-day supplies of the hydrochloroquine going out of pharmacies unless the person had a valid diagnosis that was treated by that drug.
So the situation that I mentioned earlier regarding the doc who was prescribing hydrochloroquine for a COVID patient. So if that prescription came through, how would it be reviewed? Probably at the pharmacy level based on notice.
It would be reviewed at the pharmacy level. There was also guidance that was put out that if a patient was leaving a hospital and was leaving with the prescription, that it would, that the review should not be as intense in that scenario. We have not heard of any problems with the regulatory order to date. We have heard that when we have seen prescriptions, pharmacists have been sending the regulatory order to the prescriber, and that has been curing the problem or helping with the analysis between the prescriber and the pharmacist. But it really is supposed to be limited to people who need these drugs for diagnoses where the FDA has approved that medication, absent hospital use of the drug.
Thank you for that. That's a good clarification. Not having memorized the order yet.
You'll get there.
I don't know.
I know there's a lot.
Yes. And every concern that's raised by a practitioner brings out a new element. So.
Yes, I will just say on S220, just to echo what Lauren Bodie said earlier, quite a few of the pharmacist prescribing that went into what is ultimately Act 91 came out of S220. And I have been talking with a few others, legislators about that bill and whether there's potential for that to move. So I do see that's really the only piece of the OPR bill that's directly related to this health emergency. And if there is legislation, I may speak to you or try and get that piece pulled out of S220.
We'll be happy to look at it and see what's possible.
Thank you.
Yeah, thanks. Committee questions. for Lauren or anyone. There, we've got an important group here with a lot of knowledge. Jen, do you have any questions? No? Okay. I have one more. Senator McCormick.
Yeah, thanks. This is an ongoing challenge to legislators, which is, as one of the protesters yesterday said before the State House, doctors should not be governing the state. And of course, they don't. We do. The people who are elected govern the state. But then you get the other one, that we shouldn't be playing scientist. We shouldn't be playing doctor. The idea is, how do we make the best use of scientific advice from people who actually are better at it than we are? You don't want to make high priests out of them, but they have some respect for their expertise. What is the standing right now with research? And perhaps someone actually already answered this, but we just had a lot of information coming at us at once this morning. Where do these controversial drugs stand? Is there no evidence that they have any efficacy at all for COVID, or is there some evidence, but then to what level does that evidence rise?
I could
And whoever
potentially
wants to
address
answer.
this.
Who had their hand up? Lauren Bodie, go ahead.
Oh, so this is going to vary medication by medication. So I'm going to speak in some generalities. The level of evidence for any particular treatment for COVID-19 is very low right now. So where most of the times that we're treating something, and I'm going to go out on a limb and say, anytime you yourself may have been treated for something, it was likely subsequent to numerous studies involving thousands of patients, hundreds if not thousands of patients, conducted over years to decades, that have guided our decision making. That is not possible right now. And there's no expectation that that is the level of evidence that is going to be considered completely conclusive. However, I think it is worth knowing that the level of evidence that was being used to suggest some of these treatments, in particular very early on, was really quite unsubstantiated. And the kind of evidence that you would use when it is a life and death situation and there is absolutely nothing else to do. However, we have progressed somewhat since that time. There has been increasing evidence that has come out, in particular with hydroxychloroquine and azithromycin, that this is indeed not an effective treatment. Again, this is all observational, as in not randomized, not controlled, not blinded. But the evidence seems to be shifting a little bit back towards the negative. And this is why I think we saw the NIH yesterday or 2 days ago, I forget which, say, don't do this, because the preponderance of evidence that is available is suggesting that the benefit does not outweigh the risk. Now, this is going to be a conversation that we're going to end up having with probably every single drug on that list, until we do have a definitive treatment that has been governed by randomized placebo-controlled trials involving thousands of patients over weeks to months to years. So I hope that kind of sheds at least kind of
no, listen, that helps. That's very good. And I think we'll also, should we pursue that angle, Senator McCormick, we probably should bring Department of Health in on this as well. And I do know that there have been some trials for some of these drugs at the University of Vermont Medical Center, and I know that there are other trials coming out that we're hearing about from Pittsburgh and Michigan and other spots. So
And so if I may make one point
sure,
on
please
that
do.
score. So there are national organizations, scientific and professional organizations who are making recommendations about therapies for COVID-19. The ones that I've been, paying attention to are, from CDC, NIH, FDA, and IDSA, the Infectious Disease Society of America, and they are fairly uniform in their recommendation of if you are using these therapies, it should be within the context of a trial. And so I think that is important to know that when we're talking about access to therapies from our community pharmacies, that's really not where the recommendation, that's not what the recommendation is. Access to these therapies should be coming ideally within the context of someone who is studying these therapies in a responsible way. So I know that that's a very idealistic view of the way medication, moves through our country, but definitely has implications on an individual level. But ideally, that is where these medications should be coming from when we're talking about COVID-19 treatment, not from community dispensing.
Thank Madam Chair.
Yes.
May I make another comment? Just yeah, I think I thank you for your answer. It speaks directly to what I was looking for. That's the insight I was looking for. We ordinarily, under ordinary circumstances, we have a very good regime, I think, that we don't dispense drugs until they've been tested for safety and efficacy. And efficacy is actually a safety issue also, because a non-efficacious drug can be a distraction. So, but on the other hand, these are not normal times. They're extraordinary times. So I'm looking for where's the sweet spot? How much usually required research do we do without? Or how much of a remote possibility of this maybe doing someone some good? How great does that possibility have to be for us to make the exception? And I think in that case, it actually is not a medical decision. That is a political decision for the committee to make, but we have to be scientifically informed to make it.
Yeah.
Which is, and I think what you're saying is that there is a very small possibility at this point that someone with COVID is going to get good results from these drugs. Is that right? Did I hear you correctly?
Yes, a small possibility that is outweighed by considerable potential harm. Which is actually why the American Heart Association and the American College of Cardiology has also weighed in on this issue, particularly for hydroxychloroquine and azithromycin, because there are very serious and very real, and what we have seen are deaths from combination of these medications, in particular due to their cardiac effects. So, no treatment is benign. And so that's also something that's worth contemplating as you are, thinking about risk and benefit of both on an individual and public level.
So the dangers, as I understand it, first of all, is side effects that can actually go as far as being lethal. Deflecting the drugs away from uses that we know are actually good uses. That we're making the drugs unavailable for the, and then also the distraction from other anti-COVID activities.
Yes, that is a risk.
Okay, thank you.
Thank you.
That's all I have, Madam Chair.
No, great. Thank you. Other questions from the committee? Okay. I do have one question. One of the things that you're asking for as pharmacists is to be able to test for folks for COVID. This becomes a catch-22 for me, because I know that when you go into a pharmacy, you want to feel safe, but at the same time, when you go into a pharmacy, a lot of sick people going in there, so it becomes that little bit of a paradox. You want to stay away, but you need to get your prescription filled. So if you're talking about testing, are you talking about having a testing center? How would that work so that you have a separation from folks who might have a chronic illness coming in to get the prescription? I know you talked about curbside, not everything is curbside, but can you just talk about that safety issue a little bit relative to testing? And then I will try to refrain from more questions. Who would like to pick that one up? Okay,
Sure, I
go
can
ahead.
do it. So I think when it comes, there's different types of testing. So when it comes to the active COVID-19 cases, I do believe that most pharmacies would not do that testing within the actual pharmacy. That would be done outside at some kind of set up testing location, because we obviously have those same thoughts and fears as you mentioned. The testing that would be done inside would be the COVID-19 antibody testing, which is, I think, probably where we're going to see our greatest, probably the greatest need for us in the future, as that's going to continue for quite some time. That could be done, set up within a pharmacy in a counseling room or even another location, and without as much fear of exposure to the additional patients.
Thank you. So do you believe that currently that antibody test is as effective as it could be? I forget what the false negative rate is for that.
I think we're still waiting. There are so many different tests out there, and I know from a community pharmacy perspective, I'm getting hit up every day with all these new tests from all these companies that we haven't been able to substantiate even have an effective test yet. So we don't know yet. But I think when we get to that point when there are tests available that we know are accurate, then we're willing to be right there on the front lines, and we have access to these customers. We're open, we're essential businesses, we're there. This is right in our wheelhouse already, and a place that people go every month, just to see the pharmacist and they feel comfortable. So I think it's the perfect marriage.
All right.
For the antibody testing.
Sounds good. So and we'll have to touch base with Department of Health and then get OPR's input on that one as well. But it sounds like something that would really be important to have out in our communities.
I'll say the landscape for this testing is evolving very rapidly. But what I do anticipate is that there will be tests that can be safely administered without requiring, these do exist currently. So without requiring like a very deep nasopharyngeal swab, requiring just either like a nasal swab or even an oral, that a patient can actually perform the swab themselves, but then the pharmacist can interpret the test and provide ancillary clinical services around it. So I think as we see that shift, and I think it becomes more feasible for this to be done in a community pharmacy setting, because we're already putting in those administrative controls currently to keep our patients safe, regardless of whether we're testing them, but just in the course of our usual care, so we can harness those same administrative controls and provide some of this testing down the road as soon as those platforms are widely available.
Thank you. All right. Committee, I'm looking at Senator Cummings, Senator Westman, Senator McCormick. Any further questions or that you might have for any of the folks who've joined us this morning? This has been very good. I very much appreciate your taking the time to help us understand this issue, all the issues that you brought to us. There are some I think we can probably have a further conversation about as we go forward. So it's been helpful, and I just want to say thank you. Committee, we're going to move away from the topic, and our agenda actually is complete. I'm going to hold committee discussion for another day. Senator Ingram is unavailable today, so we'll wait until she's had an opportunity to listen to the Zoom meeting, and then we'll broaden our conversation. Tomorrow morning, we meet again at 9:30 with a joint meeting of House Healthcare. And that, I think, Jen, is there anything you want to add? Okay. So I think that does it for us. You have a few minutes of your own.
Mhm.
So thank you all. And we're, Nellie, or Julie rather, will end the meeting at this point. So thank you very much, everyone. It's been very good. It's been very, very enjoyable. Thank you.
Thank you.
Okay.
Thank you, everyone.
Take care.
Ending the live stream.